Thank you, Dr. Kuresh. I'll be talking on updates on endothelial keratoplasty. You all know that endothelial keratoplasty is important for corneal endothelial dysfunction. There are varieties of indication, especially in India. The pseudophakic bullous keratopathy is the main indication. There are others like Fuchs endothelial dystrophy, eye syndrome, failed DSEC, failed PK, viral endotheliitis, SHADE, and many others. Like 20 years back, only option for Fuchs or PBK was PK. And if you see then there is evolution in endothelial keratoplasty procedure. And if you see the milestone from 1996 to 2007, then currently the DMEC is the procedure of choice. And you see that this is US graph, and 2011 and 12 actually EK surpluses PK. So DLEC was stayed for only 3-4 years. It was a little complicated procedure. It was never popular. But in India also 2-3 surgeons at that time was performing DLEC, and that was the beginning. Then DSEC started with the advancements of Desmet stripping that was introduced in US in 2004. A relatively faster learning curve than DLEC, and with significant advantage of faster visual rehabilitation, smaller wound, and intact ocular surface. But the only big hurdle was manual dissection. In India, we started at the same time like 2005-06 with speedy adoption. Then in 2006, the microkeratom was introduced by Gaurav, and that was for donor dissection, and many more corneal surgeons started doing the DS-AIOC procedure, automated procedure. But what really brought DS-AIOC into the mainstream, that donor preparation by the eye banks in USA, which is called pre-cut tissue. In India, microkeratom was introduced little later in some of the big institute, and pre-cut tissue supplied by the eye bank since I think 2004 and 5. Many Indian surgeons still prefer manual dissection, which matches with Indian economics, and PBK more happen in camps and with NGOs set up, and the incidence is higher. So manual dissection is like easier, and also you have automated now have different heads of microkeratom, like 400 micron heads are there. You have to remove the diseased endothelium, and you have to replace by endothelium, DM, a little bit of posterior stroma. This is actually DSEC procedure. And advantage, you all know that it is now established over 15 years. Predictable cell loss, long-term results are available in the literature, and it can be used in any kind of endothelial dysfunction. But relatively delayed rehabilitation, hyperopic shift, poorer visual quality, and higher order of abrasion, and higher rejection rate in comparison to DMEC procedure. Though DMEC is the choice of EK procedure, but in some eyes we still need to do DSEC, like advanced Fuchs dystrophy, where the visibility is very poor, where anterior chamber stability is not that good, post-trap, tube, post-VR surgery, some of the PK cases with large irectomy, aphakia, and in other words, any eyes where DMEC procedure is difficult. So these are some example, like this is advanced Fuchs dystrophy. We can do like manual SICS can be combined with manual DSEC. Then we have like huge corneal edema with overhanging bleb, and you can do the same procedure like bleb repair with DS-AIOC in the same time, and the patient is doing fine. This is like, you can also do phaco combined with DS-AIOC procedure, and these patients are going good for a long time. This is another indication, post-therapeutic keratoplasty, where the patient's paying ability and other factors are there, the AC stability is not there. You can combine IOL with DSEC procedure. This was my 4th case, over 12 years, he is doing very nice and going good. Then what is wrong with it? So if you see the dissect procedure, it is 80 to 120 micron more, not anatomically perfect, and also visually the increased higher order abrasion. So now DMAC procedure, and you see the post of day 1, the corneal thickness come down to almost normal, and there is a high chance of 20/20 vision. So it is perfectly anatomical, and so edilmang more. So if you see the US, there is increasing shift of DMAC among the EK procedure. From total EK, if you see, they are doing huge number of EK, like 30,000 close to, and their DMAC procedure is like 29% nowadays. In India, right now, maybe 25% of our all keratoplasties are EK procedure. We do not have exact data, but we can extrapolate from the big institute and some surgeons. And more than 100 surgeons are doing EK procedure, maybe 25% are doing DMAC procedure. So DMAC, the visual rehabilitation is very quick, maybe within a week, no or minimal hyperopic shift, good quality vision nearer to 20/20, and least rejection. But the most problem is the difficult and very steep learning count and higher donor detachment rate. Long-term data are only few. So the first hurdle is the donor preparation. In US, the surgeons are spoiled. They get pre-strip, pre-stamp, pre-stent, preloaded donor, but in India, all DMAC surgeons prepare their DMAC roll during the surgery, and donor damage during donor preparation may be between 1 to 4%. So this is the way we do. Most of the time, there are little difference in the technique. It takes few minutes, maybe 2 to 5 minutes in different, and when you learn the skill, you will maybe within 3 minutes you can do it. So you prepare, then you put a punch on the stroma. This is for marking of the stromal side, put an S mark, and your desired button is prepared, usually 7.5 or 8 millimeter donor is your. Then this you stain it with Tryphon blue, and your graft is ready. You shift it to the Petri dish, and your graft is ready for the injector system. So this, initially the second hurdle was donor unfolding or unrolling because of difficulty in understanding of DM scroll in it type. Now we know that there is a difference in anterior chamber fluid dynamics, some physics is there, and S mark is very important to help the correct orientation. There are other asymmetrical marks are there. It is going smoothly in most of the cases. So this S mark is basically life is easy, especially in brown eyes. So we have also F and P marks. So the donor unrolling is, when you learn the technique, it is not so difficult. You can do it within a minute or two, and you have to learn the ticks, how do you roll the that particular scroll. You have to use no-touch technique using 2 cannula or 1 cannula, 1 fine iris repositor, and you just open the DM and you tap it, and it has to be worked under shallow chamber. When you do it, and you can just totally unroll the situation and then put a little air, and your surgery is done. Centering is sometimes difficult, sometimes most of the time it is easier. So air bubble you give and keep the patients for 1 hour in lying down in position. So this is the results, one eye dissect and one eye DMAC. It is highly satisfying. The specular cell loss is same in both the groups. And if you see that, this is one of the new indication. Previously we used to do dissect. Nowadays, when this is failed over a period of 7, 8, 9 years, then we are doing dissect in this. So there is a good report in academy, ophthalmology by the report by the academy, and you see that overall graft survival after DMAC is 92 to 100% with a follow-up of 5.7 to 6 point. And DMAC seems to be superior than DSEC by introduce of less refractive error and less risk. So DMAC learning curve is very steep. That's why there are other alternatives like ultra-thin DSEC, where it is between 51 to 100 micron. Then nano-thin DSAK, NT-DSEC, it is less than 50 micron. The ease of handling of the tissue, also there are hybrid DMAC. Then we have PDEC from our own, Dr. Amar Agarwal has popularized it, and where the mean graft thickness is like 28 micron. And you can use the younger donor tissue in this PDEC surgery. Result is comparable with the DMAC procedure. Then coming to hemi-DMAC, water DMAC, these are basically potential method to increase the donor pool. And the results what are coming is quite satisfactory. Then DMAT is the descemet membrane endothelial transport. Then ultimate outcome has published in last year, and it doesn't work. So DMAT is out in the scene. And this is our series. We have done more than 500. The results is going good. And mostly we see a lot of Fuchs dystrophy in our part. And when you learn tricks, you can take up the difficult cases like these or that cases. You can still try, and you can have a very good results after 6 months. So then what next? That is the minimal invasive procedure or injection of cultured endothelial cells. And you know that Kinoshita from Japan has popularized is they are doing a little bit scraping of the endothelium at the central part, then inject the cultured endothelial cells, head down for 3 hours, and then it is done. So you are just injecting, and they are including the ROCK inhibitor, RO kinase inhibitor, along with this for bullous keratopathy, and they have published their result. And the before cell injection and 2-year cell injection, you see the results are very good and very satisfying results. So from one donor, you can use thousands of patients. And lastly, little about, can we go without endothelial keratoplasty? The concept is also coming, DWEK, D-W-E-K, the desmotorexis without endothelial keratoplasty, especially with FACD. And there are a lot of reports are there in the literature, and it works in some of the FECD cases, and typical indication is central Fuchs dystrophy or central focal edema or near periphery, normal periphery with good cell morphology. And it is otherwise a good candidate for DMAC procedure. It can work. I have tried last 2 years I am trying this. This is my first experience in right eye. I did DMAC, and the left eye I did DOEC procedure. This is the patient, and you see that day 1 it is worsening picture, but 1 month it is clearing, 6-12 vision, and with the cell count is still coming from the center, not this is follow after 3 months and 6 vision, and you see from the retroillumination picture that the desmotorexis was done. But what I was surprised by when I took up the second case, right eye I did actually DMAC, PBK, left eye I take later on, I did FECO with DUEC. This was in January 18. And you see the day 1 picture, then day 7, month 1, month 2, month 6, month 7, without any RO kinase inhibitor. Patient received only steroid for 3 months, then hypertonic saline, and I waited. And this is the picture after 2 years in right eye, and you see that is with DMAC and DWEC with FECO in the left side it is, and BSC, both eye 6-6. And if you see this one, there is a notch in the anti-segment OCT in the central, like 4-5 millimeter area. And you see the rexis is, now I learned that the rexis should be very smooth and regular. I did 5, 4 of them are going good. They are all having very good 6-6, 6-9 vision. One is partially resolved, and I started with RO kinase eye drop. Probably you can delay the DMAC procedure sometimes because you do not like the endothelial cell count in this group, though the count is showing higher, but the morphology is not good. So this is one of the options we have. So the possibilities are like some of the EK procedures are highly invasive, like DSEK, DSAK, ultra-thin nanothin DSEK or DMEK. And other side, if the patient comes in early stage, you can have drug therapy or minimally invasive surgery. So take-home message is in India, we have to do a lot of EK in any form. In last few years, we are doing more than 6.5 million cataract surgery per year. We are producing a lot of PBK every year. We have also Fuchs dystrophy. Surgical and visual outcome of manual DSEK or DSAK is same. DMEK is a new area with excellent outcomes. Newer innovation of drug or cell culture or DUEC are exciting. Thank you very much for your patient hearing.